Welcome everyone this morning to the Charlotte morning meeting. I'm Brent. I work at the Witwatersrand Gordon Medical Center from the Division of Geriatrics, and it gives me extreme pleasure to announce the speaker this morning is Anu Abraham, in fact, Africa's youngest geriatrician and the founder member of the Charlotte Division of Geriatric Medicine. She is going to chat to us on the often taboo subject of geriatric incontinence, which is not a wildly popular geriatric theme. Unfortunately, it's just a very important one. So we look forward to what she has to tell us about this important topic. Thanks, Annie.
Thanks, Prof. Just wanted to double check. Jared, can you hear me?
Yes, we can.
Okay, thank you. So morning, everyone, and welcome to the Geriatric Talk on Incontinence. So amongst all the geriatric syndromes we have, I think incontinence is by far the most prevalent and sadly the most neglected of syndromes. So this partly stems from various reasons, but commonly there's a misconception between or amongst patients, families, and even us healthcare professionals that incontinence is part of normal aging. So hopefully with this presentation, I can demystify that. I can let you know there's a number of investigations that needs to be considered. And certainly from a physician's perspective, there is a lot we can do to improve the quality of life and even contribute to a cure of the syndrome. Okay, so I'll jump straight into our case presentation. I'd like you to meet Mrs. P. She's quite a stereotypical case we'd see in our clinic. She's an 8-year-old lady. She is a widow, lives alone in an apartment. She's got type 2 diabetes, hypertension, osteoarthritis of the hands and the knees, and she complains of urinary incontinence for the past 2 years. She complains of frequency for 10 times a day, 3 times at night. She uses 4 to 5 pads a day and 1 to 2 pads at night. She says that there's mixed symptoms of urgency, but also occasional stress leak, but predominantly it's the urgency that bothers her the most. There's no hesitance, there's no sensation of incomplete emptying, there's no red flags such as dysuria, recurrent urinary tract infection, or even hematuria. She says her bowel actions are soft, and she drinks about 6 cups of water a day and 4 cups of coffee. Her drug history is not terrible, but she's on metformin 1 gram BD, amlodipine 10 milligram daily, furosemide 20 BD, celecoxib 100 milligram BD, and the last 2 drugs, if you are around a geriatrician long enough, you'll see these 2 drugs really rub us the wrong way, and that's oxybutynin 5 milligram TDS and lorazepam 0.5 milligram Noctay. On examination, you see that she walked into your room with a slow gait. She's got difficulty getting up from the chair. She's slow to undress. There's postural hypotension on her BP check, and she complains with some dizziness. You notice that there's bilateral pedal edema. On the pelvic floor examination, you'll see that the sacral sensation is intact, good anal tone, and there is no stool impaction on her DRE. There is also no evidence of pelvic organ prolapse, moderate atrophy, and you'll see that the Kegel maneuver is weak. She also noticed there's a positive cough test. Mini Mendel was 26 out of 30. So the definition of urinary incontinence is pretty simple: involuntary loss of urine that occurs with bladder pressure exceeds that of resistance to flow. So the prevalence varies with age. The international prevalence is about 30 to 65%. Women have a significantly higher lifetime prevalence compared to men. If you're a community residing woman, whether you're aged above 60 or 80, your prevalence is about 30 to 35%. However, if you are a community residing man, your prevalence increases by significantly every decade. If you're a doctor that works in a home care institution, then you'll find about 50 to 80% of your patients being incontinent. The problem with these numbers is that most of these studies rely on patient or self-reporting. And so with the misconception that I talked about just few minutes ago, but also with embarrassment and low self-esteem. Patients are often not forthcoming, and you really have to ask them this about these troublesome symptoms. So the effects of urinary incontinence on health, the take-home message in this slide is it's not just about the incontinence. There's a whole host of complications that arises that if left untreated, it can have devastating effects on the elderly. So there's increased risk of falls, fractures, nocturia, and associated sleep disturbances, lack of energy, chronic fatigue goes without saying, and skin irritation and pressure ulcers. Psychological well-being can be affected anywhere from just being frustrated, embarrassed, and all the way to depression. It's certainly, incontinence is the most commonest, or one of the most commonest reasons for institutionalization, and there's definitely a link with mortality as well. If you look at the costs, there's direct costs. That's the money that you need to buy pads, diapers, dry cleaning agents, paper towels, costs of treatment and diagnosis. But there's also indirect costs. For example, a patient or a caregiver who's working, taking care of someone who's got incontinence can be quite an expensive and time-consuming process. So loss of wages and loss of productivity is at stake, and definitely intangible cost. You know, the classic story is we get a granny who wants to visit her grandchildren across the town, but she's just too scared to climb the taxi because she's scared to leave a wet seat behind. So there's certainly some real life consequences to urinary incontinence. Just to put it in perspective, this is an advertisement from a famous pharmacy we have, and it's just a pack of 14 diapers will cost you 229 Rand. So definitely an expensive commodity. So as I said, incontinence is not part of aging, but there are a number of age-related changes to lower urinary tract system that puts the older person at risk of incontinence. We can go through them. So if you look at the bladder, as you age, you got a decrease in bladder capacity. There is also a decrease in bladder compliance. So the bladder is not able to sustain the tension during bladder emptying. And there's also involuntary bladder contractions. There's an increase in that, making the older person more apt to develop an overactive bladder. There's also a decreased sensation of filling. So compared to a younger person, you'll find that in an older person, there might be an increased post-voiding residual volume. So volumes up to anywhere from 50 to 100 milligram can be absolutely normal for an older person. And there's also, lastly, an decreased ability to postpone voiding. The anatomy of the bladder for the female is relatively simple. You've got the bladder, the internal sphincter, the pelvic diaphragm, and the urethra, whereas in the males, you get again the bladder, internal sphincter, followed by the prostate gland. And all of this is supported by the pelvic floor muscles. So as one ages, especially in men, you get increased prostate volume, and that can result in 50% of men or older men describing symptoms of obstruction. So this is a pelvic floor. It's quite a complex structure with lots and lots of muscles. These muscles act as a sling. So they're attached to the pubic bone. And when you cough or sneeze, for example, these muscles contract, kinking the urethra and helping you maintain continence. So as women age, especially with the history of childbirth, these muscles tend to weaken and predispose to incontinence, especially stress incontinence. So we talked about muscles. Next is fascia. There's a lot of fascia to keep the pelvic organs in situ. And women with poor pelvic support as a result of pregnancies or a history of pregnancy or even childbirth, where they have sustained injury to the fascia, in later years, they can develop, for example, bladder prolapse once these fascias weaken. The female urethra, so this is a cross-sectional diaphragm. So you'll see the lumen, and then you can see these epithelial lining, and there is the longitudinal muscles, and between which there is a submucosal veins. So when you age, especially in women with estrogen loss, you get loss of or supportive connective tissue. So these tissues atrophy. So you lose these you can say they're wrinkles. You lose the the ringly architecture. So suppose there's one place you want to have wrinkles, but you lose that connective support, and then older women would have lower urethral closing pressures. So nocturnal polyuria is a quite bothersome problem, and this is as a result of variations that comes with age to their diurnal antidiuretic hormone. Fortunately, there is a definition, and this is where a nocturnal polyuria is where there's more than a third of the 24-hour urine production. So, and when we are younger, we have a peak of antidiuretic hormone overnight that helps us to avoid from, being able to get up all the night to void ourselves. But as one ages, that peak kind of flattens out. And even in advanced age, that peak flattens out completely. So you actually get no antidiuretic hormone, and they present with nocturnal polyuria. So the nerves supply to the bladder, there are a couple of important nerves that run from T10 and below to and from the bladder, but these nerves run all along the spinal cord. And once they enter into the cerebrum, there are two major centers, and you've got the voluntary cortical center situated in the frontal cortex. So this enables you to sense the bladder fullness, and you're able to void when it is appropriate. And then you've got the pontine micturition center, which allows the whole continence process to be coordinated. So as one ages, and there's an accumulation of especially cardiovascular disease with white matter defect in the brain, and those white matter changes can occur predominantly in the frontal lobe sometimes, and therefore you can lose this connectivity between the two centers, and essentially you get like a reflex avoiding pattern. So just to explain the neurology or the nerve innervation of the bladder, you've got the parasympathetic nerves helping you to contract the bladder and relax the sphincter, helping you in voiding, while the sympathetic nerves are there to relax the bladder and contract the internal sphincter, helping you to maintain continence. There's also the somatic nerves, which supply the external sphincter through the pudendal nerves. So there are certain factors that predispose to chronic urinary incontinence. If you look at the first three factors, vaginal childbirth, pelvic organ prolapse, post-urethral resection of the prostate, you would tend to think that, these are all uro or urogyne related complications, and they're the ones to manage this condition. But I beg to disagree, because if you look at the rest of the list, there's a whole host of medical conditions which we as physicians can potentially treat, and also resulting in improvement or even cure of the urinary incontinence. So there's definitely a strong link to obesity, and I will explain later how that predisposed to chronic urinary incontinence, but then also obstructive sleep apnea and COPD. So how these disorders work is you got an increased intrathoracic pressure, which results in an increased ANP or atrial natriuretic peptide, which then in turn increases your renal sodium excretion. So you get an increased production in urine, and patients can complain of both day and night symptoms. There is lots of research to show that where once you treat obstructive sleep apnea, the frequency or the symptoms of incontinence improves. Normal pressure hydrocephalus, smoking, constipation, cognitive decline, and neurological diseases can predispose one, but also diabetes mellitus, which is an independent risk factor. The mechanisms here are numerous, but also hyperglycemia can increase your urinary volume and ultimately cause detrusor dysfunction. The last few diseases, peripheral vascular disease, CCF, and even venous insufficiency, here you've got an increased pedal edema or peripheral fluid accumulation. And when you go and sleep at night, the fluids redistribute themselves into the systemic circulation, and this can contribute to nocturnal polyuria. So when you see a patient or an elderly patient with incontinence, first try and take a screening questionnaire. This is taken from UpToDate. There's 3 simple questions, and these help you to decide what type of incontinence there is. Does it work with Does it happen with physical incontinent activities, so like coughing, sneezing, or exercising? Does it occur with urgency? And I just wanted to touch, it's not the urgency that like normal people feel. It's sudden, unexpected, and just overwhelming sensation that you really need to get to the toilet fast. And then there's obviously a mixed version. So that helps you to decide what type of incontinence it is, but then also it's important to decide and see what is the degree of severity, the frequency, as well as the duration, and what day of or what time of the day does it happen? Is it mostly during the night or during the day? And to help you with that is we call it the bladder diary. So we ask patients to fill out the time, the day of the time of the day that they drink fluids, the volume of urine they pass, the leaks, and the pads that they use. So certainly this chart does not help you to decide whether it's, differentiate between the different incontinences, but it can give you an idea whether the fluid intake is related to incontinence. It gives you an idea about the severity of disease as well. Another important aspect of history taking is drug. I don't think I can emphasize this enough. So drugs play a huge role on how the bladder functions. So our biggest enemies are once again anticholinergics. These impair bladder emptying, causing retention and overflow incontinence, and also contributes to delirium and a sedative effect. So where patients are unable to register the signals that they're receiving from the bladder. Hence, you end up with a functional incontinence. And I'll go through the different types of incontinence a bit later. Anticholinergics also contribute to constipation and fecal impaction, again, resulting in overflow incontinence. There are numerous antipsychotics, even atypical and the typical ones that have anticholinergic effect to them. And then the next one is calcium channel blockers. We commonly use nifedipine, amlodipine, which impairs the detrusor contractility and causes retention. Alcohol, we know from it causes frequency and urgency, but also sedation and delirium. Alpha adrenergic agonists like methyl dopa, when used in men, can cause outlet obstruction. Alpha adrenergic blockers, for whatever reason you use it in a female, can cause a decreased internal sphincter tone, resulting in stress incontinence. ACE inhibitors, we know it can be associated with cough and therefore sometimes can result in urge leaks. SGLT2 inhibitors, we know that they do increase urinary tract or your risk of urinary tract infection, but also urinary frequency. Another aspect you need to look at, is there any things that you can reverse incontinence? So is there a transient cause of incontinence? And this is a very apt mnemonic. You can use that. It's called diapers. And this was reported in the NEJM back in 1985, looking all the reversible causes. We've gone through the drugs, but also watch out for delirium, infection, atrophic urethritis, but also some endocrine disorders resulting in hypercalcemia or hyperglycemia. So when it comes to examination, for every geriatric syndrome, but for every geriatrician also, our examination actually starts as the patient walks into your room. So we assess the gait pattern, and if you find it to be precarious, or you see there is an imbalance, and this is kind of the gait that they will be going to using when they're going to the toilet in the middle of the night. So these patients are high risk of falling. We assess their speed, we assess their ability to undress. So that's an indication of their manual dexterity. So how well can they unbutton themselves? Do they have that speed? We also look at orthostatic hypotension, because when you're feeling dizzy, that can impair obviously your gait. Peripheral edema, we talked about. We always palpate the bladder for distension, especially after a void. And in examination of the pelvic floor, always look out for signs of estrogen deficiency on the skin. Look out for atrophic vaginitis. And on the picture on the far right on top, you'll find there's a urethral carbuncle, which is a sign of estrogen deficiency. It's quite a benign pathology, and it doesn't contribute to incontinence per se, but there's also other features looking like valvular excoriations. Sacral sensation, so this is where we put our patients in the lateral decubitus position, and we look or feel for the saddle sensation. That's S2 to S4, and this is because many of our older patients have, for instance, spinal stenosis or spinal lesions that can contribute to emptying of the bladder or a defective emptying of the bladder. And then once again, a look out for pelvic organ prolapse. That's the picture on the far left at the bottom. They're showing a posterior vaginal wall prolapsing at the hymenal region. I just want to let you know, a pelvic organ prolapse per se does not cause incontinence. There is an increased association with pelvic organ prolapse and urgency or urgency symptoms. Certainly, you can have pelvic organ prolapse and coexisting stress incontinence, especially with stage 1 or stage 2 prolapse. However, when the prolapse advances, you'll find that the symptoms of stress incontinence are actually relieved because the prolapse presses against the urethra and obstructs it. And once you are able to treat that prolapse either with a pessary or in means of surgery, you'll find that those symptoms of stress incontinence actually come back. Always important to look out for anal wink and a digital rectal exam, especially in males, looking out for the prostate, but also for fecal impaction. We ask them to do a Kegel maneuver, and this is where we ask them to contract their pelvic floor muscles. And sometimes you'll see that elderly women and men, commonly they are unable to locate their pelvic muscles. So you'll find that they'll just shrug their shoulders or contract their gluteal muscles, but nothing really happens at the pelvic floor. But there are ways that we can help them out with this maneuvers or exercises. And next is the cough test. It's very kind of specific for stress incontinence. And then finally, the neurological examination is quite vital. We always miss these to do these examinations, and we render the patients incontinent without proper investigation. So always do a cognition gait check as well as checking out their manual dexterity. Investigations, there are really few that we like to do. Urinary dipstick or an analysis to look out for infection, a hemoglobin, an HGT to make sure they're not diabetic, a UNE and hypercalcemia we talked about, and a PSA. The last two, for example, the post-voiding residual volume, I wouldn't say it's a requirement for the initial assessment, especially for stress or urinary incontinence. But for example, if your diagnosis is uncertain or your initial therapy is ineffective, or if there's concern for urinary retention and overflow incontinence, a post-voiding residual volume can be of help. Lastly, the urodynamic studies and cystoscopies. Yes, they're costly, they're invasive, but we generally refer to the urologist or the urogynecologist if we pick up these red flags. I won't go through the whole list, but just to mention a few. So if there is a sudden onset of incontinence, associated pelvic pain, if there's hematuria, so that you're looking out for a non-benign lesion, then as well as if evidence of a recurrent urinary tract infection or new neurology, those are some important reasons to do a urodynamic study. So the next couple of slides, I will go through the different subtypes of subtypes of incontinences and how we manage them further. So firstly, we got stress incontinence, and this is where there's an involuntary urine leak, as I said, with exertion. So sneezing, coughing, or lifting a heavy object. And there's two mechanisms to this. So one is the hypermobility of the urethra, and this comes in people who have chronic cough, obesity, or even difficult childbirth, and they end up with loss of connective tissue to the urethra. So you essentially end up with a hypermobile urethra. The second is an intrinsic sphincter dysfunction, and this is where often we see it in patients who've had multiple pelvic surgeries, even for stress incontinence itself, and it's quite a difficult disorder to treat. History and examination we went through. We talked about the cough stress test as well. And we mentioned that obesity as well as previous vaginal deliveries is an important stressor, but also don't forget smoking and estrogen deficiency. So you tend to ask in terms of treatment, we start off with lifestyle modification, and you will wonder, is there really a lot of evidence for lifestyle modification? And unfortunately, there's not a lot of randomized control trials to say that lifestyle changes actually work. So this is Cochrane Library Systemic Review done in 2015, about 11 randomized control trials, where there's roughly about 6,000 participants. And for sure, they showed that weight loss in those who are overweight seems to be the most beneficial for improving symptoms of weight loss. And then there's the issue of fluid in restriction. So you'll often find, older person will tell you the days that they are leaving a home or moving out, they will restrict their fluid intake. There's not really a whole lot of evidence to support this. And the issue is that, the bladder epithelium is quite an active substrate. So once you concentrate that urine by drinking less, that concentrated urine irritates the bladder and actually worsens your incontinence. So we really encourage, if there's no other contraindications, for our patients to drink about 6 to 8 cups of fluids a day. As you can see, it's quite a difficult sell because, intuitively, you drink less, you pee less. But most of our older patients actually don't drink enough. So we do encourage this aspect of fluid hydration. Other lifestyle modifications, for example, we talked about weight loss, but also caffeine. Again, the information out there amongst researchers is that it's just mixed, or there's conflicting conclusion whether caffeine really helps or reducing caffeine intake really helps. I mean, for example, there was one randomized control trial shows that caffeine above 200 milligrams can affect urinary, especially urgency symptoms. But I think if your patient is taking 1 cup a day, I don't think it's going to make a big difference, especially in our older population. Many of them do enjoy their caffeine in the mornings, especially. Alcohol, we talked about. Stop smoking, definitely, and also treat your patient's constipation. We know constipation can cause chronic straining, weakening your pelvic floor muscles, but also the fecal impaction itself can cause pressure onto the bladder. So that results in even under or sometimes even overactive bladders. Physical exercise, there are some observational studies to show that it does improve, especially urgency symptoms. But again, physical exercise is something we encourage in all of our patients, especially if there's issues of mobility and gait imbalance that's affected. So with the help of a physiotherapist or biokinetist, patients can improve their strength, helping them to get to the toilet in time. Fortunately, there's a couple of better research as well as randomized controlled trials to show there is actually benefit to pelvic floor strengthening or behavioral therapy. So one of them is pelvic floor muscle training, the other one is bladder training, which I'll come to. But pelvic floor muscle training is quite an effective modality for both stress and urgency symptoms. There is research to show that it's better than placebo, and sometimes it's even better than even drugs, especially when it comes to urgency symptoms. So what we ask our patients to do is contract their pelvic muscles three sets of 8 to 10 contractions. Repeat this about 3 times a day, every day, and do it about for 15 to 20 weeks. So yes, you do need a motivated patient. And like I said, sometimes patients have difficulty to localize their pelvic floor muscles. And here is where we get the physiotherapist to supervise these exercises. And sometimes they can even use a biofeedback mechanism, which is where they put a sensor into the vagina, which gives you a positive visual or auditory feedback as when the muscles contract. So just helping, aiding the older person to contract these muscles effectively. There is no long-term benefits to biofeedback in terms of improving their continence, unfortunately. Bladder training, this is particularly useful for patients with urge incontinence, but it can be helpful in patients where their stress incontinence occurs at higher volumes of urine. So here what you do is when you look at the bladder voiding, you find the minimum time that they can maintain their continence. So example, if it's just 1 hour that they are continent for, then every hour you take them to the toilet and they have a void, and then the next day you increase the time to 1 hour 15 minutes, and so 1 hour 15 minutes, every 1 hour 15 minutes they go to the toilet. So you're actually modulating the bladder to train itself. And then you do this until you reach a point where you can maintain continence for 3 to 4 hours. You need about 6 weeks to maintain to have a successful outcome. And yes, it is labor intensive. You do need a motivated patient, but like I said, it can be as likely as effective as drugs. We talked about estrogen deficiency. This is a systemic review showing estrogen vaginal creams or even pessaries can improve incontinence. It can take about 3 months for patients to perceive a treatment benefit. But just be aware that oral systemic estrogen is not to be used for stress incontinence or any form of incontinence, in fact, because it worsens the whole disorder. And this is thought to be because estrogen alters collagen metabolism, and therefore it changes or damages the connective tissue around the urethra. So when it comes to pharmacological treatment, we give patients a 6 to 8 weeks trial of non-pharmacological treatment before you think about drugs. Other indications are if you have a younger patient, about younger than 65, for example, and they have fewer risk of adverse events, others who have fewer comorbidities, those who are cognitively intact, or those who just have severe symptoms for a long period, and therefore you weigh the risks and the benefits with these patients. So what do we have for stress incontinence? So duloxetine is a potential drug. We know that we use duloxetine for for depression and anxiety or even neuropathic pain. So where duloxetine works is right here at the external sphincter. By blocking the serotonin noradrenaline reuptake, you're allowing the pudendal nerves to fire away and contract the external sphincter. So you would lessen the symptoms of stress incontinence. So here are 2 studies to just show that duloxetine had significantly improved patients' quality of life, and one study that it decreased frequency up to 50%. In Europe, it is approved for the treatment of stress incontinence. However, in South Africa, it's still off-label use. So certainly we don't advocate for the use of duloxetine for just stress incontinence. However, if you have a patient with depression and or anxiety, and you think they will tolerate the side effect profile of the drug with coexisting stress incontinence, then those patients can be a good candidate for the use of duloxetine. So the side effects commonly we encounter is nausea, so it's important to start at low doses and titrate up very slowly. Surgical aspects for stress incontinence, I won't go through this too much, but we know it offers the highest success rates compared to conservative therapy, and the mid-urethral sling is by far the most investigated procedure. Of course, you have to look at the risks and the benefits for every patient before you consider surgery, and looking also at their medical and functional status. And this are just 2 studies to show that looking whether you do these mid-urethral sling procedures for younger or even older patients between the ages of 75 to 85, there really is no difference between failure rates or complications. So age per se is not a contraindication for surgery. There are also urethral bulking procedures. So this is where a bulking agent is inserted into the urethra. And this is for patients who have persistent or recurrent symptoms of stress, and or those who you want to avoid or cannot tolerate an invasive procedure. It has a lower cure rate, and one of the drawbacks is that you need additional top-up injections because these bulking agents can be absorbed by our system. You need to go back for injections every 12 to 18 months. Indeed, it's an invasive procedure, so there are a number of adverse events associated with that. Stress incontinence in males was commonly associated with some sort of a prostate surgery or transurethral section, and there is evidence for non-pharmacological therapy here. Duloxetine is an option, but also the urethral bulking agents that I've mentioned just now. Going on to urgency symptoms, and we know this is where you end up having an urge to void immediately, and it can occur with a urinary leak. We do use the term overactive bladder interchangeably, and this is just, you have the symptoms of urgency, nocturia, and urinary frequency together, but it can occur with or without incontinence. It's more commonly in women, and the mechanism here is detrusor overactivity, and that leads to just involuntary detrusor contractions, especially during the bleeding bladder filling phase. There are various causes, from neurological disorders as well as bladder abnormalities. The treatment for urgency is pretty much the same. We give them a 6 to 12-week trial of the non-pharmacological management, lifestyle changes, pelvic floor exercises. So here the pelvic floor exercise is slightly different, where our aim is to suppress the urgency. So we ask the patients, when you sense that urgency, to quickly contract your pelvic floor muscles. And so another term they call it is the quick flick maneuver. And so help to surpass the urgency feeling. And once that's over, they're able to get up and go back to the toilet in a timely fashion. And again, with bladder training we talked about. So in terms of pharmacology, I guess the new drug on the block, or new kid on the block is mirabegron. These are beta-3 adrenergic receptors, so which are located into the receptor agonists, which are located on the bladder detrusor muscles. And once you activate these receptors, you relax the bladder muscle and increase bladder capacity, especially during the filling phase. You start off at low doses of 25 milligram and increase slowly by 50 milligram after 4 to 8 hours, depending on response. The contraindication to this drug is if you have an uncontrolled hypertension, for example. You can see at the end of my slide, they've written in bold to avoid anticholinergic use in elderly and frail patients for urgency. And this is because I had to add this because, in the standard medicine guideline or essential medicine list, under overactive bladder, you'll see that oxybutynin is a treatment of choice for detrusor hyperactivity. Unfortunately, oxybutynin is a highly anticholinergic drug. And this, if the side effect of retention doesn't put you off, there's a whole host of other side effects, such as hallucinations, confusion, dry mouth, blurred vision, which all can impair the elderly person remaining continence. But also there's this evidence to show from a systemic review that anticholinergics, there's a clear link between their use as well as the development of cognitive decline in the older person. So more reason not to use this drug, especially in the old. Third line interventions for urgency incontinence, I won't go through them, but they have shown to be of quite significant efficacy, sometimes up to 50%, depending on which article you look at. But there are various things that you can be done, such as tibial nerve stimulation, sacral modulation, as well as botulinum toxins. Urgency in males, commonly a neurological problem, but also benign prostate hyperplasia can contribute. And the treatment is to treat the cause. And there is a role for mirabegron only if you exclude an obstruction. Mixed incontinence, essentially, it's both stress and urgency, and the treatment is pretty much the same. You treat the predominant symptoms. Overflow incontinence, I won't go through because I think we're all commonly familiar with this. And in females, quite a rare condition, but most of the time it's as a result of bladder outflow obstruction. And the treatment is to treat the underlying etiology. Functional incontinence, lastly. And so this is where, the patient's urinary storage or emptying function is completely intact. It's normal. But these patients, because of their comorbid physical conditions, they are just unable to get to the toilet in time. And this can be as a result of blindness, poor eyesight, poor spatial perceptions, visual spatial perception. So, here the patient, especially in the middle of the night, they're unable to locate where the bathroom is in their house. They're unable to locate where the toilet is within the bathroom. So that impairs them. Other issues of manual dexterity we talked about, they just can't unbutton themselves fast enough. Neuromuscular disorders or neurological conditions that affect their mobility, and even postural hypotension, which we did mention. So fortunately, we geriatricians, we have a couple of tricks up our sleeves to help with this condition. Firstly, we advocate for patients who have mobility issues, providing them with mobility aids, as well as wall-mounted handrails, helping them or aiding them into getting safely onto the toilet seat. Certainly a high raised toilet seat with armrests can help the older person with less effort to get in and on and off the toilet. And especially we know in our elderly patients, they have weak quadriceps muscles. So a high raised toilet seat can be of most benefit. I did mention just now about the patients who have poor visual spatial perceptions. So just changing the color of the toilet seat, if everything is white, like the toilet floor is white and the toilet is white, they'll have difficulty to localize where it is. But if you can change the color of the toilet seat, it helps them to recognize where exactly the toilet is more appropriately. Again, urinals or commodes, especially when put next to the bedside during the night hours, can be quite helpful. So we got finally Velcro or adaptive clothing. So this is where we help place Velcros or zip-off pants or elastic waistbands. And I often think this is like the older person's best friend, because the few seconds that it takes to unzip or unbutton yourself, it can mean the difference from being wet or dry. So definitely a useful modality for older patients. So when we go back to Mrs. P, if you ask what type of incontinence it is, and frankly, like all geriatric syndromes, it's actually multifactorial. So we know she complained about stress symptoms, urinary urgency, and stress. So it's important in these kind of patients to divide all the different multifactorial issues and address them independently and see what you can do. So why would she have the urgency? So we know she was on furosemide, and there was no really indication why she was using Lasix. There was no evidence of heart failure. There was some pedal edema, which we could treat differently. And so I would really stop that furosemide that she's on. Caffeine intake, we talked about it. If I will ask her to maybe reduce her 4 cups to maybe 2 or 1 cup a day and see if it makes a difference, carry on if it and that can be beneficial sometimes. Control her diabetes a bit more, maybe with the use of modified glycoside addition of that. Why would she have nocturnal polyuria? Is it because of the peripheral edema caused by the non-steroidals or the calcium channel blocker? So I would consider changing over to a paracetamol or change the calcium channel blocker to an enalapril. And then ask about why would she have enuresis, bedwetting at night? So is this the lorazepam? Or definitely down titrate that and stop the furosemide at night. The stress incontinence, we noticed weak pelvic floor muscles. So with the help of a physiotherapist, we can improve that aspect. And finally, the functional incontinence, treat the arthritis or help with an OT, as well as a biokinetist to help with the slow gait that she has. So thank you. It's a whole lot to talk about, and I hope it all made sense. And I'm happy to take any pressing questions. Thank you, everyone.
Thanks, Annie, for a wonderful talk, which beautifully covered a lot of these complex aspects of urinary incontinence in older folk. It's a bit of a minefield, and it's a huge burden of disease on older folk. Just for the audience, obviously in state, the beta-3 agonists are not available. They cost about 500 Rand a month. So basically 2 packs of nappies, 28 nappies. So this is not a cheap problem or syndrome to have and to try and manage. But thanks, Annie.
All right, thanks everybody. If there's no questions, I think we can close our talk for today. And I hope everyone has a lovely Friday and a lovely weekend going forward. Thanks everyone. Goodbye.
Thanks.